These are our check-in forms. These are our admission forms. This shows all the information about not only the owner but the patient. This has her segment right here. Her name is Chloe. She is a 5-year-old female spayed dachshund. Her last weight was about 17 pounds. The reason for her check-in, she's here to have a dental cleaning today. This also shows her current reminders as far as her vaccinations, heartworm tests, fecal exams, heartworm preventative, things of that nature. If she had any prior diagnoses, they would be listed here as well, but this particular patient does not. This form will serve as her medical record in a sense. Our practice is very paper light. Also, for patient identification, when they check in, each patient has a collar printed out for them that has all of that same information on it. Patient's name, client's name, contact information, and the patient's signet. And they wear these the entire time they're in our clinic. Medical consent form. This is our form for the owners to give us consent to perform any kind of surgical treatment, procedure or medical treatment. Again, we have all the owner's information, patient signet up top, emergency contact information, procedure being performed, as well as anything additional to a standard procedure that the owner would have requested. In this case, looks like we're checking in for a dental, and then we're also going to trim her nails. We also have a block for how the owner would like us to contact them when their pet is out of surgery. In this case, we're going to contact them as soon as Chloe is awake from her anesthesia, and then again when she is ready to go home. This is a disclaimer saying that your pet will receive pain medication at the doctor's discretion, saying that we will take every reasonable action we can to protect your pet against any kind of harm. Other procedures that we recommend while your pet is here, of course, pre-operative blood work. We do not always require it. Usually it is an optional thing. So in this case, we are going to perform some pre-operative blood work, and the owner declined a home again implant. Once again, we have our vaccinations down here. Vaccinations, heartworm test, fecal. She is current on all of these things, and the estimate amount for this particular procedure. Down here at the bottom, this is office use only. This is where, once we do our physical exam on this patient, we'll assign her an ASA grade. We have her emergency drugs worked up, her weight and TPR here, and then her anesthetic protocol is also, our general anesthetic protocol is also listed out here unless we make any kind of changes. This is a urinalysis form, and again, generally these things are entered directly into the computer, so these forms don't typically follow the patient. The computer follows the patient. In this particular case, we are recording the number of milliliters that we collected, the color, the clarity, the pH, specific gravity, and then of course just your general urinalysis over on the side as well. Our anesthetic monitoring chart, again, kept in the computer, so this one is not filled out because we have not yet done this procedure. We have up here her IV catheter, where it is placed, what her fluid rate is going to be, the medications that we use, both for a pre-medication, her induction, whether or not she's maintained on inhalant anesthetic or injectable, and then we also monitor these parameters. So we're monitoring her inhalant anesthetic, what the flow rate is there, her oxygen flow rate, IV fluids that she may be receiving. She's on a constant rate infusion of pain medication, that will be monitored here. Her blood pressure and mean arterial pressure is monitored here. Temperature, heart rate, respirations, her SpO2, end-tidal CO2. We also measure her mucous membranes and CRT. Down at the end, we also keep record of any pain medication that she was given intraoperatively, as well as when the surgery ends, when anesthesia ends, was extubated. Again, her ASA grade is down here, along with her emergency drugs that are already worked up. Chart, including her discharge instructions. So this chart will mark not only any teeth that we may have found that were already missing, any kind of teeth that we had to extract, of course fractures, pockets, things like that. Anything that we find that's abnormal will be marked on this chart. We also will take a picture, her before and after dental pictures will be inserted here. Whether or not her blood work was acceptable for anesthesia or any problems that were found there. Her anesthetic protocol is also listed. the parameters that we monitor during her procedure, and then her home care instructions, saying that her mouth may be a little tender, she may be groggy from anesthesia, just your general discharge instructions. This is Chloe. She is a 6-year-old female dachshund. She's here. We're going to do a dental cleaning on her. So we're going to start our physical exam with just kind of checking her overall outward appearance. Her eyes are bright and clear. Her ears are clean. She is grade 3 dental tartar. Gums are good and pink. No nasal discharge. Submandibular lymph nodes are slightly enlarged. Skin and coat looks good. I don't see any evidence of fleas. Feet and her nail beds look fine. Go ahead and get her temperature while we're back here. Temperature is 1015, perfectly normal. I know. Okay, let's lay her back down. She's obviously obese, so her palpation is a little difficult, but I don't feel anything abnormal, nothing enlarged, or certainly no pain. All right, let's give her heart and lungs. sounds great. Her respirations are clear. The lungs are clear. Heart rate's about 150. Respirations are about 40. So based on her physical exam, we'd give her an ASA grade of 2, meaning that she has maybe some mild systemic disease, probably stemming from the amount of dental tartar that she has. So we'll definitely do some pre-anesthetic blood work on her before we do her dental cleaning. Lateral saphenous blood draw from a dog. Our alcohol preps. Jugular venipuncture. This is our canine cephalic blood draw. Venipuncture on a cat. Come over here, Kobe. Tiny little vessels. Cephalic venipuncture of a cat. Very happy cat. Minimum database would include PCV, total solids, a blood glucose, and a BUN. So our PCV stands for packed cell volume. It's a measurement of the amount of blood that's comprised of red blood cells. An increased PCV can mean that your patient is dehydrated. A decreased PCV can mean that your patient is anemic. Your total solids is a measure of plasma proteins. Our blood glucose obviously is a measure of our blood sugar. It's important to remember that several factors can influence blood glucose readings. Things like stress, whether or not that patient ate recently or was fasted for a surgical procedure. Those things can adversely affect your blood glucose readings, so important to keep that in mind. Our BUN stands for blood urea nitrogen. It's an evaluation of our kidney function. That's important to keep in mind because a lot of our anesthetic drugs are metabolized through the kidneys, so we need to make sure that our kidneys are going to be able to get rid of that waste product. Additional databases may include, depending on what is found in the physical exam and from our minimum database, they may include more comprehensive blood work, including a chemistry panel, a CBC, an electrolyte panel. May include radiographs, sides of the chest, the abdomen, depending on what's found elsewhere. If available, it may also include things like ultrasound. Certainly if we have a sick and injured patient or a geriatric patient, then likely these additional tests would be ordered. For Chloe's procedure, we will be using an inhalant anesthetic. We will pre-medicate her with butorphanol. We will use propofol as an induction agent. We use it to effect. Typically that's between 4 to 6 mg per kg, but again it's given to effect. Then we will intubate her and we will maintain her on isoflurane for the duration of her dental cleaning. And then we will use Rimadyl as post-operative pain relief. She'll get an injection of Rimadyl during her procedure, and then she'll likely be sent home with some Rimadyl as well. Both the butorphanol and the Rimadyl are going to provide her some pain relief while during the procedure, and like I said, the Rimadyl will take care of it afterwards. If we have to do any major extractions or anything like that, the doctor may elect to add something on board as well. Of a controlled substance log. The practice that I work at uses, we are a paperless practice, so everything is recorded in the computer. So this is a mock log, but this is basically what they all contain. Each drug has its own specific log. This one is for ketamine. The vial is labeled individually. It has a unique ID number. We have the concentration, the size of the bottle, and then when we actually get to logging the use, we have the date, the animal that it was administered to, the person dispensing, the amount that was dispensed. This particular log requires initials of the person who administered it, whether or not any was wasted, initials of a witness, and then at the very end we have the remaining balance. Okay, this is our anesthesia machine. We're going to start off with our oxygen supply. Our intake on the back here, it is turned on and it is full by this gauge here. Comes through a pressure reducing valve up to our oxygen flow meter. This controls the amount of oxygen and the rate that our oxygen and anesthetic gas mixture is delivered to our patient. Our oxygen fast flush valve is here. This is used to, if we are trying to rid the system of waste anesthetic gases, if we're going to allow our patient to breathe oxygen for a little while afterwards, we can use that to flush, obviously providing that these are off, to flush the anesthetic gas out of the system. We have our vaporizers up here. This particular machine has both sevoflurane and isoflurane. They are in line. It's very important to only have one of these on at a time. Let's see, we have our fill valve separate on here. It's also very important to make sure that we're only filling ISO with ISO and SIVO with SIVO. So definitely some attention to detail comes into play there. So once we have our patient, we have our anesthetic gas on, our oxygen flow meter on. That mixture is delivered to the patient through their tubing. This is connected to the end of their endotracheal tube. Once they exhale, it comes back through this tube, through our unidirectional exhalation port. This manometer here keeps track of the amount of pressure that's in our system, so we keep an eye on this as well. This is, by the way, this is a rebreathing system. Once our patient exhales, it comes through our scavenger system here. We have both a soda lime canister, which helps to absorb excess CO2, as well as a charcoal canister here to help get rid of some of those waste anesthetic gases. So our pop-off valve, this is what allows that process to happen for those gases to get through our scavenger system. Very important that this remain open. Closing it can lead to an excessive buildup of pressure within our system. For right now, we're going to close it and we're going to perform a leak test on this machine. So the first thing that we're going to do is close our pop-off valve completely. We're going to include the end of our tubing, make sure our reservoir bag is tight. I'm going to use this fast flush valve to fill this reservoir bag up to about 40 centimeters of water. And then we're just going to make sure that it's holding pressure. Okay, and we're going to make sure that our valve is open completely when we're finished again. Other options, we also want to show you an example of a non-rebreathing system. This is good for smaller patients. It doesn't require as much respiratory effort on behalf of the patient, and we're also constantly delivering fresh oxygen to them. They're not rebreathing any of their expired gases. It does require a little higher flow rate, but it's easier on our very small patients. This is an example of a mask that can also be attached to the end of these tubes rather than an endotracheal tube if we're using a mask for induction. Our cephalic overhead.
Would you hand me that flush, please?
All right, we're going to place a saphenous IV catheter in Captain. Borax and an alcohol rinse. Strip. Okay, so this first one's going sticky side up. We're going to butterfly it over our catheter. Okay, and this catheter is good. Oops. Just an extra piece of tape just for safety's sake. This is Mandy. We're getting ready to induce anesthesia. We'll prep her and take her in. She's being spayed today. So we've made sure that she is, of course, the correct patient. We've verified the procedure that she's here for. This is Dr. Smith over here for our direct supervision. So first we're going to make sure that we have everything together that we need. We have all of our anesthetic drugs calculated. We have our endotracheal tubes, several different sizes that we've measured. This is what should fit, but of course we always want to size up and size down. We have our anesthetic machine, our oxygen supply, our laryngoscope over here for intubation. For as soon as we get her clipped, we also have our gurney and our towel ready to place her on so that we can scrub her and get her into surgery. So the first thing that we're going to do is we're going to make sure that these cuffs don't leak. Flushing her IV catheter. Pre-medicate her with hydromorphone, giving very slowly. For induction, we're using dextromethorphan ketamine. relaxes a little bit, we'll get her intubated.
Notice that right here.
Okay. We're going to lubricate her eyes and we're going to get her on some oxygen while we prep her. We're going to give her a sub-Q injection of Rimadyl for post-op pain control. And then this is just saline. We're going to give a straight IM injection. Keep saying we. Toby, stand still. Please.
That's all?
Lift her up. She's bleeding somewhere. Radial infection. Here on the other ones. transport our patient into OR. So we're going to disconnect her oxygen. She's having liquid diarrhea, Doc. Alright, and she is still just on some oxygen. Okay, you can run your cover. Yes. Can you see this? Mm-hmm. You have to see all the numbers. Okay, so we're monitoring her heart rate, her pulse oxygen, she's a little bit low. But she's climbing. Her blood pressure's down here, including her mean arterial pressure, her end-tidal CO2, respiration rate, her temperature. All of that is recorded electronically in the patient file. Okay, if our patient were to go into cardiac arrest, the first thing that we would do, of course, is alert the rest of the team and make sure that we have help coming. We're going to make sure that we have an established airway. Obviously, our patient is intubated, so we do. If I was just here by myself, then I'm going to concentrate on cardiac compressions. Be more important to giving her cardiac compressions will allow for adequate ventilation if there's not a second person here to bag. So on a dog this size, we would be doing compressions at the widest point of her chest. She's in right lateral incumbency, so she's on the right side. And then if we were getting ready, while I were doing cardiac compressions, we would have another person bagging her, and they're just going to close this valve, squeeze her bag, watching this manometer, making sure it's not going over 20 centimeters of water. Sterile surgical scrub, so we're going to start off by lint rolling, just making sure that we get any excess hair. Okay, the outside of our gown pack has been opened. Can you time it?
Thành được uống được.
Our sterile field, the outside of this pack has already been opened. We have our strips showing that it is in fact sterile. The first thing that we're going to do is organize our instruments. Count our gauze pads. It's labeled on the outside of the pack, but we always want to double check. There are 10 pads. We'll count those again when our surgery is complete. We're ready to drape our patient. We're going to do a 4-towel drape. Let me drop that on here. Okay. Ready for our blade. We're using our needle holders. Place this blade on the handle. I'm going to make sure it's on there completely. And then if we were going to pass this blade to a doctor, it's important to remember that the cutting edge of the blade be turned away from both my hand and his hand, and I'll place this in his hand just like this and hold it there firmly to make sure that he has hold of it. If we were passing ringed instruments with a curved tip, we're going to make sure that the first ratchet is closed. We're holding it by the box lock, and once again placing it directly in his hand, making sure that he can grasp it and it's ready for use when he uses it. Same procedure with the straight tip, making sure that the first ratchet is closed, holding it between the box lock. And then with our thumb forceps, again, making sure that the tip is pointed down and that we're placing it firmly in his hand so it's ready for use. Okay, if care of exposed tissues, what we would be doing, we would have a bowl on our sterile field filled with sterile isotonic solution and a gauze pad placed in it. We use this gauze pad in that field and just squeeze it over the tissues. We don't want to rub or block the tissues. Same thing for blotting excess bleeding. We're going to use a dry gauze and just blot the bleeding away instead of rubbing and potentially removing any coagulation that's already happened. The duties of a sterile surgical technician are to maintain asepsis at all times, to assist the surgeon with maintaining an orderly, sterile field, making sure that all the instruments are organized and easily accessible, passing those instruments to the surgeon when needed, helping to care for exposed tissues, and helping to ensure hemostasis when appropriate. In order to keep a sterile field, it's important to note that as sterile personnel, your sterile area once you're gowned is from your shoulders to your waist, the front of you only. So you keep your hands up in front of you, not above your shoulders, not below your waist. Anytime that you are moving around the room, which we want to limit because we want to limit airflow, but anytime that we are required to move around the room or change positions with someone else in the room, it's important to either move with sterile to sterile or non-sterile to non-sterile. So you're either going to be front to front with someone or back to back. It's very important to never turn your back to a sterile field. Cleaning of our surgical suite. So the first thing that we're going to do is survey the room and just make sure that there is no obvious clutter, dirty surgical instruments, anything like that left out. Trash is emptied daily, of course. Our bucket is cleaned. Our table is disinfected and wiped down. We use an HDQ neutral solution. The tray in this table is also removed daily and cleaned and disinfected before it is replaced. Our mayo stand, the same way, the top of it is removable and the entire stand and legs are wiped down and replaced. All of our equipment is also wiped down. We have our surgery specific fluid pump, as well as our Bear Hugger body warmer. Our prep table is also kept clean and clutter free. Make sure that nothing is left up there. Of course, our surgical packs, everything is closed and put away. We do have a basket that's in here right now for surgical laundry. All of our dirty surgery laundry goes into this bag and is washed separate from any other laundry. We also have a broom and a mop that are specific to this room. Of course, we're looking, the blade has already been removed. Any sharps are going right down here in our sharps container. So, like the rest of these sharps have been removed. And I'm just placing these instruments in some warm water, some instrument detergent. We're going to let them soak for just a few minutes. Not going to place our sharp there. We're going to set our sharp to the side, and that will be dealt with later. So we're going to let those things soak for a few minutes. We have a soft bristle brush. And we're going to take these instruments and just gently scrub. Make sure that all the moving parts are clean. It's also important to move these ID bands. Make sure that they're clean as well. Do a couple. ordinarily we do all of these instruments at once, but again, for time's sake, I'm going to rinse them in cool water. And again, just do a brief visual inspection and make sure there's nothing there. Okay, they're placed in a surgical instrument lubricant, surgical milk. They're allowed to sit for about 30 seconds. It's also important to move the moving parts and make sure that they're well lubricated. This particular solution is not rinsed off. It's allowed to dry on the instruments themselves, and they're laid on a clean absorbent towel to dry. Our instrument pack. The first thing that we're going to do is organize our instruments. So this is just a standard spay pack for our clinic. We're just going to organize these from largest to smallest. All the hinges are open. And then we're using our thumb forceps to keep them together. Okay, we also have our scalpel handle, and we have our towel clamps in here as well. We're going to set those off to the side for a moment. So we have two drapes here, our larger and our smaller drape. We have gauze. These are each 10 pads of gauze, so a total of 20. We're going to take a sterile indicator strip, put our gauze pads out. Just put a strip right in the middle of it. And our towel clamps. We have our paper drape that's folded accordion style. And it is also, it has a tab for the surgeon to grab. And then we're also placing a towel in here. And it's folded accordion style with a tab as well. So, we're going to start with the side closest to us. We're going to fold it up accordion style. Nice and snug. We're leaving our pull tab sticking out. We're going to do the same thing with our outer wrap. So once that's wrapped, we're going to use our autoclave tape. And we're going to date it, initial it, write what type of pack it is, and how many gauze are in it. Fold and wrap our surgical gown. So we're going to start by laying it down flat with our sleeves up. Fold our sleeves in. Bring the outside edges into the middle. On top. We're going to have a sterile indicator strip in the middle of this. We're going to set that to the side for just a moment. We'll get our linens back out. So we're going to start with the large linen. Place our smaller one on top. There's our gown right in the middle of it. It's another indicator strip. And we're also going to have our accordion folded hand towel on top of this as well. Trying to make it pack it nice and tight so it'll fit in the autoclave. And once again, we have our tab sticking out. surgical gown pack. Again, we're going to place our autoclave tape. And we're going to date, initial, write what size gown it is, autoclave procedures and maintenance. So this is a steam sterilizer. It's an older model. We use distilled water in it. It's filled through a reservoir back here in the back. And there's a fill line inside. Once our reservoir is filled, there is a fill switch here that we'll use, which will move the water from the reservoir into the chamber. So we're going to depress that, which I've already pre-filled it because it takes a second. So we've held this down, filled up our chamber up to, again, the fill line with water. Then we're going to take our packs, which each have a sterilization strip in them. The packs themselves also have indicators as to whether or not they're sterile. So we're going to take these packs, they're not touching each other, they're spaced out. Whoops. And we make sure that they're not touching the sides. They're not touching the sides, they're not touching the bottom of the tray above them. Everything has room for the steam to move around. So once our packs are in, close our door. Our temperature control is already preset for where it needs to be, so we're going to start our timer. We usually set it for about 10 minutes. It doesn't typically take that long, but we're going to watch our temperature control. Right now this light is indicating that it is heating, so we're starting to build up some steam and pressure. Once this, usually takes about 5 minutes to build up to about the 260 degree mark. In order for these packs to be sterile, we want them to be at least 250 degrees Fahrenheit for at least 13 minutes. So that's generally our minimum standard. What we typically do is we run it at 260 for 15 minutes. Again, once this heats up to our desired heat, then we will change our timer and set our timer to how long it needs to stay at that heat for our sterilization time. So again, for the sake of time, providing that we had already sterilized these, we stop our timer. This particular model, you have to pop the door to this position. Had it had pressure in there, the door would not have vented, and we would hold this lever down to allow that steam to vent, and then we leave it in this position for at least 15 minutes, and that'll allow those packs to dry without getting any strike through from the steam. So then once they're completely sterilized and dry, we can open this up. They should be cool to the touch by then, and you can remove them. These steam indicator strips will have changed colors to let us know that they are in fact sterile. So autoclave maintenance, our general daily maintenance is just wiping this out with a mild detergent solution. We just wipe all the surfaces that we can reach. We wipe off our trays as well. And then monthly, the manufacturer recommends using a product called Speed Clean. We actually change the distilled. We drain the reservoir through here, make sure that it has fresh water in it, and then we place the Speed Clean in the chamber itself and run a cycle through. We do not run instruments through when we're cleaning it. We usually run a pack of gauze or something that can be disposed of. but we'll run that through it, and that helps to keep some of the scale from building up on the inside of the autoclave. Once we remove our packs from the autoclave, the steam chemical indicator strip will have changed from a pink color to a green color. Surgical needles. So the size and the shape of the needle is going to depend on the type of tissue that you're going through, how strong that tissue is, whether or not it's a hollow organ, things like that. So the shape of the needle, there are several different shapes. You can have a cutting edge, which this is an example of. It's hard to see, so we'll come back to our PDS. So this is a reverse cutting. Having a cutting edge makes the needle passage through the tissue easier, but it does actually create an incision, so this is not going to create a sealed suture line. Our incisions here can leak. It's important to not use an actual cutting edge inside organs that we don't want to leak, things like the intestines, the bladder, obviously things that we need a sealed suture line in. A taper needle is a round needle. This is an example here. And what this does is it actually just kind of spreads the tissue apart for the needle to pass through. So this will give us a sealed suture line. This is very popular for use in hollow organs. So there are two different ways that the suture can be attached to the needle. We can have an eyed needle. In a single-eyed needle such as this, it's very important to only thread the suture through once. Going through twice can create a big knot, or not a knot, but a bulk of suture right here, which obviously pulling that through the tissue is going to create more tissue damage than is necessary. And then we have eyeless needles, where the suture is already attached. These are ideal. This means that each time you get a package of suture out, you are using a brand new sharp needle. As you can see, there's no bulk at the connection from the needle to the suture, so that's actually considered atraumatic. These are preferred in veterinary industry. This particular needle, I got this one out as well. This needle is something that's commonly used in large animal. It's large enough to be manipulated in the hands. Of course, you could use a needle holder as well, and this is typically used for skin lacerations and things of that nature in large animals. Suture material. We're going to start with bronamide. This is a synthetic non-absorbable suture that we typically use for skin sutures. In fact, it should only be used for skin sutures because the way that this particular suture is comprised, the outer layer can break down and it can lead to infection. So we definitely only want to use that in the skin. We're going to move on to gut, which is not something that's commonly used anymore. This is chromic gut. It is a natural suture. It is absorbable. The way that it's absorbed, it causes an inflammatory reaction, which means that the rate of absorption is also variable, so it can be difficult to determine. The rate can vary depending on the level of inflammatory response as well as the type of tissue that it is placed in. We have silk suture, which is an organic. It is technically classified as a non-absorbable, but because it is organic, it does break down. It has a complete loss of tensile strength within 6 months. So, but it is still considered a non-absorbable suture. It can cause a pretty severe tissue reaction, and it does have some wicking properties, so it can move infection and things like that. It's most commonly used in cardiovascular surgeries. This is PDS. This is our go-to absorbable suture in our practice. It's a synthetic product. It's tensile strength. It lasts for more than 21 days. It's very easy to use. These two are examples of two different sizes and different needle shapes. So this is an example of a simple interrupted suture pattern. As you can see, each suture is its individual, has its own individual knot, is not connected to the suture next to it. Disadvantages of this is that it is very time consuming. Advantages are that if one of these sutures comes loose, you're not losing the integrity of the entire suture line. We use these on some spay incisions that animals are likely to have a problem with. So these are two examples of mattress sutures. The one on the left is your vertical mattress. The one on your right is a horizontal mattress. Both of these are used for incisions, wounds that have a large amount of tension on them. They are both strong suture lines, and like I said, they're typically used for areas where the skin or the edges are very tight and there's quite a bit of pulling. Cruciate pattern. Again, this is a very common suture pattern. Our doctor prefers to use this for all of our spays when it's appropriate, of course. Again, this creates a very strong suture line. Each cross is its own individual suture, so they're not connected to each other. Example of a forward interlocking. This is something that we more commonly use in large animal. It's a very strong suture line. It's quick, it's easy, and large animals that tend to rub, even though this is a continuous line, if part of this comes apart, it will typically tighten down on itself and not allow the entire incision to come apart.
Post-surgical suture removal. I apologize, I do not have a video of myself performing a post-surgical suture removal on a patient, but I will gladly explain what that process would entail. So a post-surgical suture removal, the very first thing that we're going to do is verify that the proper time has gone by. That amount of time can vary depending on the type of procedure that was performed, as well as several other factors, including how that patient, how good they were with their incision, whether or not there was any damage to the incision afterwards or anything like that. So once we've verified those things, physically the first thing that we're going to check is we're just going to look at the incision and make sure that there's no redness. We're going to look for signs of swelling, any kind of discharge. We want to make sure that the incision itself, that the skin looks normal and healthy, certainly that the incision is completely closed, that there are no gaping areas, missing sutures, like I said, areas of infection, obvious discharge, things like that. Once we've verified that none of those factors are present, then we'll go ahead and remove those sutures. We'll do that by grasping the tail or the knot of the suture with a pair of hemostat and using suture removal scissors to actually clip the sutures out.